All right, welcome to Powerhouse MD. Today we are going to go over schizophrenia spectrum disorders. So we're going to start off with a case presentation. A 20-year-old male is brought into the ER by his girlfriend who has been concerned with his most recent behavior. For the last 2 months, the patient has been stating that he does not believe his girlfriend is really his girlfriend, which has caused him to lash out and mistrust. For the same duration, she says he hears voices telling him to hurt her because she's not who she says she is, but her boyfriend still doesn't want to hurt her. Before these symptoms started, she recalls a period of 4 months when her boyfriend was apathetic and disinterested in things he used to find enjoyable. The ER physician tries to get a more detailed history from the patient, but refuses to speak to anyone. What is the physician suspecting? So not trying to start with anything too hard yet, I want to start this straightforward by covering schizophrenia. So before I get into things, I just want to highlight a couple things from this vignette. 2 months, doesn't believe his girlfriend is really his girlfriend, hears voices. And then before, for 4 months, he was apathetic and disinterested. Here's what I want you to think about that I'll get into shortly, but what type of delusion is this patient suffering from? All right, so let's get into the epidemiology of schizophrenia. Approximately 1% of the population suffers from schizophrenia. There is no gender bias. According to resources, though, there's a 1.4 male to 1 female, but this is not statistically significant. Now, typically, the onset is late teens, but is slightly later onset in females. Late onset is over 40, but they are more likely to have positive symptoms and is a less severe course. Childhood onset is less than 13 and is a severe form of the disorder with more deficits in neurodevelopment. This is typically associated with low socioeconomic attainment, nicotine addiction, and suicide risk with aggressive tendencies. We'll get into that a little more later, but this is just the basics of what you need to know. So the diagnosis of schizophrenia disorder requires one or more of these 5 domains. Delusions, hallucinations, and disordered speech or thinking are the core domain symptoms. At least 2 of them must be present for more than 1 month. This is considered the active phase, which again, we'll get into, to be considered schizophrenia. Now, in the next slide, we're going to go into delusions, but for now, I'm going to break down the rest. Hallucinations are sensory perception without an external stimulus. In this case, it's usually auditory or derogatory. Disorganized speech or thinking is when speech or thought lacks the normal logical connection between words or thoughts, such as derailment, loose association, or word salad. If severe, a differential diagnosis needs to be made against aphasia, which has phonemic paraphasic errors, like saying flow for slow. In schizophrenia, it's mainly the connection between the words that is going awry. And then you have disorganized behavior, which can be non-goal-oriented behavior, or catatonia, which is multiple motor or behavioral abnormalities that reflect diminished reactivity to the environment. And then lastly, you have your negative symptoms, which we'll cover after delusions. Delusions are fixed false beliefs that are not amenable to change even with conflicting evidence. In vignettes, it's not just important to identify whether the patient is having delusions. It'll be important to identify the type in case that is what the question wants. So different sources have different types of delusions you need to know. Here are the 10 main ones you need to know. I include them because they're really straightforward and you need to be able to identify them because I have seen questions with each of these delusions. So that's why they're included. So first you have delusion of grandeur. This is grandiose thinking, and they typically have the idea that they're the center player on the world stage. Then you have persecutory, which is paranoia, one most people are aware of thanks to TV shows. Then you have somatic, which is just concerning body health. Then you have Capgras delusions, which is someone replaced by an imposter, like I gave you in the vignette. Then you have delusions of control, which is an external forces controlling one's behavior. Then you have delusions of reference, belief that an external action refers to or has special meaning to oneself. Thought broadcasting, which can be a big one, is thoughts being transmitted to others. You also have erotomaniac, which is holding false beliefs about a relationship or love, for example, being convinced that a celebrity is in love with them. Then you have religious, thinking that they have a special or unique connection to a religious figure or deity, or even that they are possessed by a demon. And then lastly, you have referential, believing that public communications such as newspapers, TV shows, or song or lyrics contain special messages exclusively for them. Negative symptoms are thoughts, behaviors, or perceptions that normally exist that are now absent or markedly diminished. You have diminished emotional expression, which can be verbal or nonverbal. You have abolition, which is decreased self-initiated purposeful activities. Alogia or poverty of speech is reduced speech output, which is signaled in the vignette as the most recent symptom. Anhedonia, which is the inability to feel pleasure. And asociality, which is disinterest in social interactions. This is different from positive symptoms mentioned earlier, which are thoughts, behaviors, or perceptions that are distorted or in excess of normal function. So schizophrenia diagnostic criteria. Prodromal and residual phases are using only one symptom. Most vignettes and step scenarios will give negative symptoms, so don't forget to check for that. There's 3 phases you need to know for diagnostic criteria. You have a prodromal phase, which is usually a little bit in the beginning, couple months, feeling some, like I said, negative symptoms, like is usually their go-to. Then you have your active phase. You need to have at least 2 of your core domains, like I talked about, delusions, hallucinations, or disorganized speech and thinking. Then you have your residual phase, which the core symptoms can go away, so be careful to look out for that in the vignette. They may show the residual phase as also negative symptoms. Overall, the signs of disturbances must be for more than 6 months. In order to fully diagnose, you also need to rule out bipolar disorder with psychotic features and schizoaffective disorder with depression. There are a couple things to note when it comes to diagnosing schizophrenia as well, though. You will need to do a mental status exam, which will confirm the symptoms I've already described. In the intro video, I go over the mental status exam with a case as well as mini mental status exam favor for dementia. In this exam, when you observe thought process, schizophrenic patients may exhibit blocking, clinging, derailment, echolalia, incoherence, neologism, and preservation. So keep those in mind for schizophrenia when you're looking through your MSEs. So there are some prognostic indicators when it comes to schizophrenia. Like I said earlier, the older the better, younger the worse. Rapidity of the onset, rapid is better, slow is worse. So if it happens really fast, you have a better likelihood of having a better outcome. Positive symptoms are usually also better outcomes compared to negative symptoms leading to a worse outcome. Usually because negative symptoms lead to some sort of suicidal ideations disorder. Keep that in mind. Structural CNS changes, absence, always better. Mood, if there's mood swings present, that's better. That kind of goes hand in hand with positive symptoms. And then female gender also has a better outcome than male. Male typically have it much worse. So some risk factors, I touched on this a little earlier. I'm gonna go more in depth now. You have urban living, immigration, cannabis use, tobacco, even advanced paternal age at conception. Please keep in mind paternal and not maternal, maternal being what leads to your Down syndrome babies. There's also winter, early spring births that have been linked to increased risk of schizophrenia. Now, some of these might seem weird, but research has shown a trend with these associated risk factors. Lastly, I do want to touch is inflammatory conditions. So inflammatory conditions such as celiac disease, thyrotoxicosis, and interstitial cystitis lead to chronic inflammation, which can cause changes in the brain that may contribute to psychosis. So again, keep that in mind. I don't think that's necessarily going to be a high-yield topic, but it is one of the interesting facts I wanted to include. Some comorbidities are present with schizophrenia. You have depression, anxiety, substance use disorder, diabetes, hypertension, and hyperlipidemia. Now, these last 3 are your metabolic effects. The increased risk of metabolic disorders may be related to adverse effects of treatments with antipsychotic medications. Again, like I said before, there's also an increased risk of suicide in schizophrenia patients. Now let's get to the fun stuff. A 20-year-old female is brought into the ER by her boyfriend who has been concerned with her most recent behavior. For the last 2 months, the patient has been stating that she does not believe her boyfriend is really her boyfriend, which has caused her to lash out and mistrust. For the same duration, she says she hears voices telling her to hurt him because he's not who he says he is, but his girlfriend still doesn't want to hurt him. The patient has never experienced anything like this before. The ER tries to get a more detailed history from the patient, but refuses to speak to anyone. What is the physician suspecting? So a couple things. We have 2 months. We have a Capgras delusion, and we have auditory hallusion. This is schizophrenic form. 2 core symptoms are present, but the period is between 1 and 6 months, not over 6 months. Remember, schizophrenia is over 6 months. Schizophrenic form is just 1 to 6 months. No real prodromal phase, no residual phase. A 25-year-old female is brought to the ER by her parents due to spending all her earnings and savings in the last month and a half. The patient states that she had found a way to make money by buying all the Gucci purses, belts, and shoes, but she had to own them first. She has not spent any money since tapping out 3 weeks ago. When asked why she felt she would make money, she stated that she is a celebrity and everyone should know her, which is why they would buy the product from her. Her parents state that this belief of being a celebrity has been going on for about 3 weeks. The patient has no history of drug abuse and the toxicology screen has turned clean. What condition is the physician expecting? So highlighting again, spending all her earnings and savings for the last month and a half. That is a sign of mania. Not spending money since means it's cooled down. It's pretty much a waiting period. She also stated that she is a celebrity and everyone knows her. This delusion of grandeur. This is going on for about 3 weeks. and there's no history of drug abuse. Toxicology screen is clean, which means we can rule out substance use disorder. So again, manic symptoms, delusion of grandeur, which is positive symptoms greater than 2 weeks, because it's 3 weeks. The majority duration of the illness is present with a major mood symptom and is not associated with substance use or previously diagnosed medical condition. This represents schizoaffective disorder. The major mood symptom could be major depressive or manic. So I use manic in this case. A 38-year-old female is brought to the ER by her parents because for the last 3 weeks, she has believed that aliens are walking amongst us to take over our lives. She states that one shared their life story and that the Selene had taken over their planet and the doctor failed to save their home. She says that any day now the doctor will come to save us and she's holding out for it. Her parents are getting very concerned. The patient has no past medical history and has negative toxicology screen. What does the physician think the cause is? First off, I don't consider believing that the doctor exists as a hallucination. He is real and he has saved us countless of times. But I think him and Dr. Song are together more than we see. Anyway, so this is a brief psychotic disorder. The patient for the last 3 weeks has believed that aliens has taken over people, which is a delusion, and has talked with one of the aliens, which counts as a hallucination. The big thing about brief psychotic disorders is one or more core psychotic domain symptoms. In this case, I gave you 2, which is delusions and hallucinations. And another big thing is it's lasted for less than 1 month. Brief psychotic disorders are less than 1 month with at least one or more core psychotic domains. It is also important to note that patient must return to normal function after this period. A 16-year-old boy is brought to the ER by his parents because for the last 2 months, he has believed that he is God's right-hand man. He was raised in a Catholic church and is an altar boy. However, he's been speaking against the priest because he feels that he's not truly saying what God wants to be said. He's constantly getting in altercations with the other altar boys because they don't follow the path of enlightenment. His parents are getting concerned and want to know what's wrong with him. The patient has no past medical history and the toxicology screen is negative. What does the physician think the diagnosis is? Hopefully you've noticed at this point that you have to establish the timelines to know a specific type of schizophrenia. In this case, it's more than 1 month, so you can rule out a brief psychotic episode. He is having religious delusions as he feels he can be one-on-one with God. This makes it a delusional disorder and the diagnosis requires no schizophrenia diagnosis or criteria be met, at least 1 delusion longer than 1 month. If there are hallucinations, they are not prominent and must be related to the delusional theme. They must be functioning otherwise normal with no significant impairment. There can be no obviously bizarre behavior. If manic or major depressive episodes occur, they are brief compared to delusions. There's no substance abuse or previous medical history. Before we move on, there are 2 other confusing schizophrenia-like disorders. You have schizotypal and schizoid. Schizotypal is magical thinking and schizoid is withdrawn and blunted affect. But these 2 will be covered in the cluster disorders videos. It was tough deciding whether or not to put them in here, but they're not really part of the schizophrenia spectrum. They're just like it. So look out for those videos and you'll get your full in there. All right, so we've covered the criteria for diagnosing schizophrenia, but this is for all disorders. How do they specifically diagnose via ruling out other conditions? So you have the ammonia level, urinary copper level, and thyroid function. These can lead to hallucinations and cognitive functions. The disorders are covered in other videos. Then you also have vitamin B12 when deficient can lead to cognitive symptoms too. You also need imaging to rule out head injuries or brain tumors. And already covered, you have your clinical interview. You need to hit the criteria as previously described. So what causes schizophrenia spectrum disorders? You have the neurodevelopmental theory. There's a lesion occurring during early brain development. The lesion can be caused by susceptibility in genes or due to maternal infections. There's no immediate effect. Effects usually start with brain maturation and can be influenced by environmental factors, which is why you have those risk factors that have shown trends. You do have some evidence being your hippocampal cellular disorganization, increased minor physical abnormalities, and increased neurological soft signs. The biggest hypothesis behind schizophrenia that isn't even fully right is the dopamine hypothesis. This is the leading theory. This stems from too much dopamine being present, but is not complete because there are other neurotransmitters such as serotonin, GABA, acetylcholine, and glutamate that are dysregulated. However, you do have correlation with it. The overactivity of mesolimbic dopamine pathway relates to positive symptoms. So blockade would decrease these positive symptoms, whereas the underactivity of the mesocortical pathway relates to the negative symptoms, and a blockade would worsen negative and cognitive symptoms. So some changes in the brain that occur with schizophrenia are enlarged ventricles. You have decreased cortical gray matter, reduced hippocampal volume, long-term could lead to dementia, decreased volume of thalamus, hypofrontality, which you have your disinhibition eventually, and then you have impairment in attention memory. So lastly, how do we treat schizophrenia then? So you have your antipsychotic drugs. You have two types. You have your classical and your atypical. Of your classical antipsychotics, you have fluovenicine and haloperidol, which are the highest potency and are more likely to produce extrapyramidal reactions, which we'll get into shortly. And then you have your low potency drugs, which would be your chlorpromazine and thioridazine. These drugs block D2 receptors in the mesolimbic pathway very strongly. Then you have your atypicals, which is clozapine, risperidone, olanzapine, quetiapine, aripiprazole, and your pimavanserin. Now, your atypicals do block D2s, but the affinity is not as strong. Like with clozapine, you have a higher affinity for D1, D4, 5-HT2, and alpha adrenergic. And then risperidone has a greater affinity for your 5-HT2. Your aripiprazole is partial agonist of D2 and 5-HT1 alpha and antagonist at 5-HT2 alpha. And pimavanserin is an inverse agonist of 5-HT2A with no significant affinity for dopamine receptors. Antipsychotics reduce hallucination and agitation, have a calming effect, promotes minimal motor and coordination, and does not depress intellectual function. They typically work within 24 hours of being administered. All have antiemetic effects except for aripiprazole and thioridazine. This is because of the blockade of D2 receptors that can trigger chemoreceptors in the medulla. Super big thing because thankfully it's the one savior of antipsychotics. Antipsychotics do not interfere with the metabolism of other drugs. So it has no effect on your CYP whatevers. One less thing to worry about. So adverse effects, just covering the important ones you should know. Atypical psychotics are more likely to cause metabolic dysregulations, such as clonazepine and olanzapine. Clonazepine can also lead to agranulocytosis around 1 to 2%. Then you have thioridazine can lead to QTC and T-wave changes, as well as retinal deposits. And then chlorpromazine can lead to deposits in the cornea. Continuing on for the adverse effects, we have the extrapyramidal reactions. This is usually associated with high D potency like haloperidol and fluphenazine. This is less likely to occur with conventional agents with strong anticholinergic activity. You have Parkinsonism. This is treated with benzotropine and trihexyphenidyl combined with diphenhydramine or amantadine. Don't give L-Dopa for Parkinsonism patients because the problem is too much dopamine to begin with. It just mimics the effects of Parkinsonism. Then you have dystonia, which can be controlled with diphenhydramine, trihexyphenidyl, and benzotropine. Then you have akathisia, which can be managed by reducing the dose, administering clonazine and propranolol. And then lastly, you have tardive dyskinesia, is the most important unwanted side effects of psychotics and can potentially be irreversible. This is caused by dopamine receptor upregulation. This is treated with discontinuation, eliminating drugs with anticholinergic actions, your VMAT inhibitors such as tetrabenazine and valbenazine, as well as benzodiazepine and clozapine. Lastly, we have neuroleptic malignant syndrome. This is a rare and life-threatening disorder consisting of rigidity, tremor, hyperthermia, altered mental status, autonomic instability, elevated white blood cells, elevated creatine kinase, myoglobinemia, and nephrotoxicity. What may be helpful in the management of neuroleptic malignant syndrome is dantrolene and bromocriptine. And that is all I have for you guys today. I hope you liked the video. Go ahead and give it a like. Go ahead and give a subscribe. There will be more videos coming to you soon. Hopefully that made schizophrenia spectrum disorders a little less confusing.